Welcome everybody to the Arizona Telemedicine Program webinar series. For over a year, we have been bringing you Envenomations, Intoxications, and travel-related diseases. Today, we have with us Dr. Klotz, Dr. York, and Dr. Shirazi, and they will be talking about Black widows and tularemia, which I probably just slaughtered that, but Dr. Klotz will give you the correct pronunciation when it's his turn. So we want to read our land acknowledgement. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples. Today, Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign native nations and indigenous communities through education offerings, partnerships, and community service. So just a couple of webinar tips and notes. When you joined the webinar, your phone and/or your computer microphone was muted. Time is reserved at the end for question and answer, so please use the chat function to ask questions. And then you will receive a post-webinar evaluation, and we kindly ask that you complete this for us. This is how we continue to curate information that is most valuable to all of you. This is a CMA-approved webinar, so it is only available during the live presentation. The webinar is being recorded, and we have a link here where you can find them after this webinar. With that, I will turn it over to Dr. York and stop sharing my screen.
All right, let me take over here in a second. Make sure I'm unmuted. All right, I'm already off to a great start. All right, so let's flip over here. So joining us, we had teased it a little bit last time. Let's get this finally pulled up here. All right, so we have got old favorites back to talk to you today. We have got Dr. Stephen Klotz, who's going to talk a little bit about tularemia, as already mentioned. We have got Dr. Mazda Shirazi joining us from the Poison Center, who's going to give us that long-awaited talk on black widow spiders. And you've got me, Dr. Larry York, doing absolutely nothing but asking these folks questions as they arise. So if you are new to this, this has been part of our, gosh, it's been well over a year, I think, this point. We've been doing this webinar series on unique infectious diseases, poisonings, envenomations of the Southwest. And I know a lot of folks here from the emergency room. We got some EMTs. And we were just looking over this, and I think we've just about hit all of our big things that we wanted to cover with you all. Now, again, if you are new to us and there's anything on here that you would like to see covered that is not written down, we have had many of these presentations dictated by suggestions from you all. So please don't be shy. If there's anything that fits within this criteria of being here in the Southwest or the Sonoran Desert, we would love to hear about it and we would love to cover it if it's something that you think would be of benefit to you. All right, so with that said, let me stop sharing on my end. All right, let me get this out of my way. All right, who's up first? Dr. Klotz, is it you?
I am, Larry.
All right, it's looking good. Perfect.
Okay, welcome everybody, and thank you for attending. As Larry said, we've been doing this well over a year, and we've had probably some 20 different topics. We usually present 2 or 3 each week or each month. And next month, we'll have one more webinar. And then in December, I think we'll take a vacation, as all of you will probably around the latter part of December. And the 3 of us will get together and figure out where we move from there. But in order to help us, please write to us in that chat box, if you will, some topics you want to hear. We can look them up, or it's likely that one of us has had some experience with any topic that you bring up, and we'll be glad to talk about it. So today I'm just giving a short little I don't know, a summary, I guess, of tularemia, which is also known as deer fly fever or rabbit fever or Pavant Valley fever. So it was initially described as a disease in humans in the 1800s by a Japanese physician who noticed that people who were feeding on hares would come in with adenopathy of the neck and high fevers. It's a rare zoonosis, in other words, a disease of wild animals or even uh, animals that we keep in husbandry. It has a small reservoir in small mammals and rodents, rabbits, and also within ticks and deer flies, as I will explain. It's a very small intracellular gram-negative bacterium. I'll show you a slide a little later. There are several subspecies, two of which are of clinical importance. F. tularensis subspecies tularensis occurs only in North America. It's highly virulent. And there's also F. tularensis subspecies holarctica, which also occurs in North America, but all throughout the northern tier of countries around the globe. It's less virulent. Here's a picture of a typical cutaneous lesion, either from a fly bite or a tick bite. It's an ulcerative, non-healing, necrotic lesion from which you can actually grow the bacterium, but it leads to a systemic illness. It's a worldwide disease in the northern latitudes. There are only about 200 cases in the United States each year, and 0 to perhaps 10 at most in Arizona at any one time. It has a higher rate of infection in Scandinavian countries. Pets like dogs and cats can become infected from wild animals, and their bites and scratches can transmit the infection to humans. And I recall one case of a young girl who died of meningitis from the disease, having been bitten by her pet cat. It's viable in flies for up to weeks and ticks for years, as I will explain later. And this is a disease we know a great deal about since the early 1900s, due to Edward Francis, whose photograph is shown here at his bench with these glass sterile tubes and cotton stuffed in the top, the way we used to do microbiology. He looks like he's smiling to me. So, oh no, he's looking through a microscope. And he worked this out, the whole disease, in the teens of the 1900s. He was a United States Public Health Service physician who was sent to the Pavant Valley in Utah, where there was what was known as Pavant Valley fever. And he was able to discover exactly what was happening here. So this will come up as we go along. Here is the microorganism, a gram stain. It's gram negative. It's a coccobacillus. So it's both a small little rod-like organism and also as a coccus. In the Western states, most of the disease in human is transmitted by deer flies, as shown here. There's a male on the left and a female on the right. Their bites are painful. They're memorable. And since the incubation period of tularemia is 3 to 5 days, people will remember, oh yes, I was bit in this site by a deer fly, or they may say horsefly. But these flies are common alongside the fast-moving streams of the northern climes within North America and extending up from northern Arizona into the Rockies. And they lay their eggs on the bottom side of a leaf alongside a stream. The eggs fall, develop into larvae, which develop over time, may have the bacterium within them already, and then it's passed on to a pupa and to an adult. These adult flies can also feed or land on carcasses of animals that have died because of infection with tularemia. It's common in Arkansas, believe it or not. The Midwest is the hotspot for this, most of which historically was related to hunters and shooting cottontail rabbits, and then which can be heavily infected. And in dressing them out, you get your hands on the liver, lesions, and so forth. And this can be passed on to the hunter or to others in the meat. It used to be a cause of problems in the New York market where hundreds and thousands of cottontail rabbits were shipped each week to be sold in the city. It's a disease that has many modes of acquisition. This is a fun disease to understand and to work up if you're a clinician. And it's something all of you should give some thought to in the particular circumstance, which I'll describe in a moment, here in Arizona. On the left, you can see it can be transmitted through small mammals like hares and rabbits and prairie dogs, for example. It's also a disease that is found in muskrat and beavers and can be inhaled from all this material on the nest site. And it's also carried often for years within an exotid or hard-bodied tick. And this is most of the mode, if you will, of transmission that occurs in the Middle West and Eastern states is through a tick. So we have tick or biting fly bites. You can handle an infected animal like a rabbit, a muskrat, prairie dogs, other rodents, and infect oneself or others around you by inhalation of material that's aerosolized. It's very easily aerosolized. And you can ingest this bacterium as well. And that was what happened when Soken discovered this amongst all the Japanese who had been eating hares. And what is true still is that people cannot pass it on to another individual. So the incubation period, as mentioned, is 3 to 5 days. It's unique because the small bacterium enters a macrophage and sets up a typical presentation clinically. And this applies to many different diseases which target the macrophage, like brucella and so forth. So you have fever, and you have this very characteristic pulse temperature dissociation. So they may have a fever of 104, but their pulse is only 60. This is a tip-off to what you're dealing with. In addition, there'll be, if it's a cutaneous acquisition of the disease, there'll be regional adenopathy, which is painful and swollen. And the spleen is often enlarged as well. The longer the disease goes on, the more likely you're going to find splenomegaly. And what is also characteristic is when you get your CBC, you look and you go, well, white blood cell count's normal, or it's very marginally elevated. This is a disease that's a favorite of bioterrorists. It's been used at least twice historically by the Japanese in Manchuria and the Soviets at the German-Soviet border during World War II. It's easy to aerosolize, and this is what makes it such a great bioterrorist organism. And just small amounts can lead to many, many deaths. The diagnosis, to confirm it, you need to isolate the bacterium. This can be done actually from one of those skin lesions or from the blood. Now, Edward Francis gave it the name tularemia to denote that it came from a small mammal outbreak around Tulare Lake in California. but emia denoted the fact that it's in the bloodstream. And in working this up, he went to the Pavant Valley in Utah, which I've driven from north to south. It's just a little bit north and west of Zion National Park. It's a beautiful area, all covered by snowmelt water that's running through fast-moving streams. And you can just imagine that out there you're going to run into a deer fly without fail. And he took blood samples from patients who were suffering with it. They had usually adenopathy or some skin lesion, injected it into guinea pigs, and sure enough, they died very rapidly, and that's how he uncovered this gram-negative bacterium. But it tells you that there's a systemic illness, i.e. that it's in the blood. So that's what the emia part of this is, even though it's rarely recovered in blood cultures because it just doesn't grow very well. And something I discovered when I was at LSU in Shreveport was that we had lots of cases of tularemia. They'd come down from Arkansas, and they'd have histories of tick bites and so forth in hunters. And we actually found a lot of disease by blood culture, which was hard to do. And I had a young man from Arkansas who called me up. He was a lab technician up there who had discovered that if he took all the negative blood cultures in the lab and then subbed it onto chocolate agar, he recovered quite a number of cases of tularemia that had never been discovered clinically. And it's just that this organism requires cysteine to grow properly. So who will claim that, and as well, the CDC, that an antibody test is one means of confirming this, or at least diagnosing this disease? The point is, it takes about 2 weeks to a month to develop the antibodies to a level where you can detect them. So your first test is likely to be negative, and a month later, when you get a second test, it can be positive. But the point of all that is you need to treat the patient for the disease in the meantime, because you're just not going to likely have recovered the organism in the blood. In Arizona, it's seen when it does occur, usually in the northern climates of Arizona, and often that may be exposure to small mammals, like a woman who died recently in northern Arizona, days after her dog came in with a dead rabbit. And probably she inhaled this, and it was a typhoidal presentation of tularemia. It's also found along the waterways in northern Arizona. So there have been kayakers on the Colorado River, which is extremely cold all the way down almost to Yuma, and following deer fly bites. The treatment is basically gentamicin, and I'm not going to go into how to treat this, but it responds best to gentamicin. Doxycycline, ciprofloxacin will work. Streptomycin, you'll see if you look it up, is the disease or is the therapy of choice. However, that's hardly ever available. And besides, the only disease it works for that the others don't is in meningitis, since gentamicin isn't going to cross the blood-brain barrier. And I think that's it. If anyone has any questions, I'll be glad to answer them now. But otherwise, I think we'll get on to Mazda's presentation on black widows, and I will stop share.
Yeah, so no questions yet, but like Dr. Klotz said, just type them into the chat. They pop up for us, and we'll make sure that they get answered. If not now, then once Dr. Shirazi finishes, we should have a bit of time left.
You're mute.
Still muted.
Here we go. I'm gonna share it before I go into a. Okay. You guys can see it. I'm gonna put it. Can you see it?
We see
Well, you gotta
everything
click
but.
on the one you want.
I did pick it, but it seems
It's behind things.
it's behind things. Wow.
Well,
We're
you've
looking
got,
at a survey for the
And I got the
telemedicine thing.
survey. I don't know how the survey came up, but I'm gonna put the survey down. I'm gonna put this down. I'm gonna stop share. I'm gonna go into share again, and there should be one. Do you guys see it now?
Nothing yet.
Oh, it doesn't share.
Oh,
How
something's
about now?
happening. There we go. We got it. We got it.
Okay, I'm gonna go into a. Can you see it now?
Perfect.
Okay.
perfect.
So we're going to talk about black widows or Lactrodactylus mactans, and that's one of the species. That's the most common one in Arizona. Again, I'm Mazda Shirazi from Arizona Poison and Drug Information Center. Here we go. So here are different morphologies. These are same types of black widows, different species, and they come with different morphologies. The one on the lower right is the redback from Australia, and the two on the top are American, and the one that you see on the lower left, we see it from Asia and other areas. I'm going to go forward. Here are where we can see these are the major, out of the 32 species, these are the major ones. So we have 3 with 1 subspecies in the United States. And again, I put the ones up, but there's the another one that looks a little bit different. And Henseleti, that's from Australia and the Pacific. And you can see that all of them have one thing in common. They have this red dark or marking or hourglass on their back or under their belly. There are others, the Geographicus, that they actually look very different. So not because everybody thinks that they can identify them, but because these species, especially Geographicus, it sort of looks like dots or map, and sometimes people don't recognize that as a species of black widow. So here we have the kingdom, the phylum, that's arthropods, the class, arachnids. The order is Araneae, the spiders, and the cobweb spiders mainly. They are a group in this genus that are false black widows or false widow spiders that look similar, but they usually have much smaller red spots. And the 3, I'm sorry, major species in the US are named here. So again, the female ones are the ones that are responsible for the major bites and envenoming or envenomation. The male ones have less of the venom. They're smaller, their fangs are smaller, and they have a harder time penetrating the skin. So usually we don't see much of envenoming with the male of the species. And depending on where you look, there's about 2,500, some report 4,000 in the US, bites in the US. Again, it depends whether people report these. The other thing is there are no deaths that are reported in major journals or CDC or the Poison Center, but on occasion we see some references that they say maybe up to 4 people die from this annually. Now, that's, I would say, a little bit of a far stretch. Here, the southern black widow is the one that me deal with most of the time. But again, you have the northern black, the western black widow, and then the brown widow. that you can see. It's the Geographicus or Geometricus that has all those nice markings on its back. It looks like a globe. And then there is the red widow, and you can see that one, the body is red. And those are the ones that we hear about. And they're in various areas of the country. But the main ones, again, it's the southern black widow that we deal with. Internationally, where do they exist? They exist almost to any place that's allows them to exist. And then when it gets cold, you don't find them. But there are case report, case series, and they are identified almost everywhere in North America, South America, in Africa, Asia, both East and West, and then in the Pacific and Australia. Now, the ones that we're dealing with are the arenomorph. These are what you call the classic or modern spiders. The megalomorph, that's where the fangs are in the front and they go back. They're parallel fangs rather than the fangs that they come together as a pinch. The megalomorph, they are more of web spiders of Australia and the tarantulas. So here we're dealing with modern arenomorph spiders. They're sort of a spiky, spherical egg sacs, and they are disorganized. You find them various places. When we used to have outhouses in Arizona, we used to get calls mainly from northern Arizona from outhouses, people getting bit in them. But we have these webs around our garages, in the sheds. And nowadays, if you go to parks, we see lots of these under the tables in the parks. And the last two Envenomations that I saw were actually in very young children, where mom parked their stroller under the table and the black widow fell into the stroller and bit the child. The peak of the bites occur usually in the summers and then followed by falls. We still see them in the spring, and it should say winter. I don't know, it says winter there. So mainly summer and fall. Again, the bite site, you can see if you examine it closely, a person that comes in, you should be able to see the site of penetration of the fang into the skin. Sometimes you have to use a lens or one of these, or even your handheld phone, but you can see it. It rapidly sort of goes into a sort of a blanched circular area in the middle with some erythema around it. There can be mild edema or swelling associated with it. Sometimes, depending on where it is, like if it's on the anterior shin, you don't see much of a swelling or minimal. Symptoms come on usually about 30 to about 120 minutes away later. However, as late as 8 hours after the bite, again, depending on where the individual has been bit, they've been reported. They last, the toxicity or the syndrome will last about 24 to 72 hours, and it will resolve. The main part of the toxin is the alpha-lactotoxin. This is the toxin that binds the presynaptic nerve terminals and releases large amounts of neurotransmitter, mainly acetylcholine. And with it, especially in children, we see lots of salivation and lots of spit forming in the mouth. In the adults, we don't see it. Now, why? It might be that they're acting as much more larger sponge. Like many others, they have also other toxins involved with it. Latrodectin is what's used actually in eating other insects and paralyzing and getting rid of the shell is the chitinase on the bottom. And the rest of them cause pain, some degree of local tissue toxicity, metalloproteases and serine proteases. And hyaluronidase is the enzyme that spreads the venom. And that's what our cosmetic industry uses to actually also spread their cosmetics in human skin. So the syndrome is called latrodectism, and it's usually in adult. You see pain. Almost everybody has pain associated with it. Autonomic instability. You can see about 30% of the patients, they get tachycardia or hypertension. 70% of people might actually have nothing. It would be normal. They're just complaining of pain. In the North American and South American species, pain is mainly involves the trunk and abdomen. They describe a stiffness of the trunk and the abdomen. Sometimes these patients have been taken even to the OR for peritonitis or concern for API that has spilled over. However, in the South America, it's actually a pain that moves proximal through the either leg or arms toward the body. And that's the main difference between North American and South American bites. We see nausea, vomiting. There is lots of muscle aches, joint aches, muscle rigidity, again, as it was, especially abdominal wall. There is diaphoresis, and diaphoresis can be very asymmetrical. It could involve half the body. It could only involve the site of envenomation. And that's one of the major signs of this bite, that there is pain. There is, again, some degree of rigidity of abdomen or abdominal discomfort. And then this atypical diaphoresis doesn't involve every place. It doesn't involve a normal diaphoresis that you see like with activity. About 1% of these are severe. So the severe ones, they require antivenom. My suggestion is that with moderate and severe to contact an expert to see whether you need to use the antivenom, and we'll talk about the antivenom. And again, I've seen these continue for about 72 hours. The site of bite, usually it's lower extremity. You can see it also in upper extremity and the trunk. And again, depending on the site, you might see the diaphoresis, the pain, the swelling, and the bite marks. Usually people can describe, except for young children, where the pain is, and you can identify the site of the bite. In infant and preschoolers, again, there's much more prominent of this salaria, or they form lots of spit, and there's lots of overproduction of mucus in their mouth. With older children, you can see much more paresthesias, the anxiety, and localized pain. Salaria might not be as prominent. There are special populations that I'm sure many of you are aware. In pregnancy, it can actually cause uterine contractions. Here we see that actually antivenom does tend to work, and the rate of use in pregnancy seems to be a little bit higher. The main treatment usually is pain medication, usually opioid, synthetic opioid, benzodiazepines, and NSAID, from those mild ones that you see. And it might have to be on a regimen for 24 to 72 hours, depending how long it's lasting. We use the antivenom when the pain is not responding and when they're having other complications. Now, the reason for that, this is like one of the oldest antivenoms on the market. It stopped. Ah, here we go. The antivenom, there are multiple countries that make them. Merck made one in 1953, and it's a full IgG. So, and it's one of the cheapest antivenoms on the market. However, because it's a full IgG and it's made in horses, there are different reports of hypersensitivity and anaphylaxis. But there are other countries that also make the antivenom. Our antivenom, again, it was made in 1953. I think last time I checked, it was like $28. It's a very cheap. But because it's a full IgG and because of package insert having 5% hypersensitivity report and 10% serum sickness, lots of people are afraid of using it. We have used it, and especially with people who had severe abdominal pain. And it's amazing that within half an hour, the pain is totally gone. Now, that is our experience, and they are our colleagues in Colorado and California have done studies, and there was a clinical trial to bring a new antivenom, a FAP2, on the market, and it showed that they played a significant role in pain reduction. However, a clinical trial in Australia did not show that, at least with their spider, the redback, that the antivenom did much for the pain. So we have this antivenom and pain relief divide between Australian and American experience. That's it. That's my talk. If there's any questions, more than glad. Let me stop sharing.
All right, no questions in the
I-
chat as of yet.
I have a question.
Yeah.
I wonder if you could just tell us a couple war stories of your recent patients with this problem. Where did it happen?
So the two most recent were children, and they had it again in the park, and they weren't together. They were two separate. It was in the summer that they presented. Again, likelihood summer, fall is higher. They went to a park, and one of them, child, actually put her hand under the table and felt something bit her. And the other one was a child in the stroller that the spider actually fell. Mom was driving when the child started crying unconsolably, and she pulled aside to see what's going on because it wasn't normal, and she found the black widow spider in the child's car seat.
Wow.
Both of them, they end up being pretty mild. And we admitted the children, observed them for about a 12-hour period, and they resolved. In adults, again, one of the worst cases I had was a lady that was actually evaluated by surgery to be taken to the OR, and they wanted somebody to hold their hand to give the antivenom. And I stayed on the phone, recommended the antivenom. The antivenom comes in a 2.5 ml vial. It actually originally was designed to be given IM, but now you can give it IV, you can dilute it more. And we usually recommend to dilute it into 50 mils of normal saline. And that way you can control the rate that you're running it. So if they have a more of a mild hypersensitivity reaction, you can slow it down, and you can even give them epinephrine, either IM or through another IV if they have a problem. But this lady did not have a problem, and she got it, and I was on the phone for a long while. And finally, we heard the patient said, "God bless you all, my pain is gone." So it works pretty fast. So
Where was she bitten?
what was that?
When and how was she
Oh,
bitten?
she was bitten actually in an outhouse, and it was one of the hospitals by the rim. I believe it was like Sholo or Payson that they called us. It's been a while. The worst war story I have on this was when an individual who wasn't actually envenomated, they captured one of these and told the practitioner in one of the EDs that she's pregnant and she's having contractions. And one of our OBGYNs, of course, to be safe, accepted the patient. And the patient got here and they consulted us. And I go to the bedside, patient is not pregnant, and she was not bit. So that was the worst war story that you hear. We actually had one of our colleagues bit. He was older. He was in his 40s, and he had the most distinct diaphoresis. It was just on the side, I believe it was on the lateral side of his left leg, that you could actually see beads of sweat forming. And he described also to us, at that time, we didn't have access to ultrasound that we have nowadays, which are like common handheld ultrasound. But he was describing also what muscle contractions, we couldn't see him, but he could feel it, that he was having either fasciculations or myokemias, which can occur actually with, and they're described with the various spider venoms.
All right, we got a couple questions. So how does the venom of brown recluses compare to black widows?
So brown recluses have much more phospholipids and they're much more tissue toxic. The cytokine reaction is also much higher. So we do see both reactive thrombocytopenia and thrombocytosis. And I think that one, the presentation was one of my fellows gave it, but we had one of our patients that we had to do electrophoresis because her platelet count went into the 2 millions. So those are well described, much more reactive. They usually present with myalgias and low-grade fever. The hyperemia and blanching, it will progress into a eSCAR or blackened center. And we actually have had 5 or 6 patients that we followed their course really closely. So pain is not the distinct feature of it, nor diaphoresis. And of course, for the brown and Arizona recluses, we don't have antivenom, but there is antivenom for black widow.
And then following up on that, is the antivenom that we're talking about today for black widows, is that available in most ERs in Arizona?
Well, it depends whether your hospital buys it or not. And I'll be honest with you, I'm surprised. Most antivenoms are thousands of dollars. And this is one of the antivenoms that the cheapest. You buy it, and pharmacies are usually, they give them a budget. They don't tell them what drugs they have to buy. But in Arizona, antivenoms after chemotherapy are one of the most expensive ones. So we know that in major cities they have them. We carry it in Banner here and at South Campus also because it's so cheap, but it's because we ask them to carry it. I think most people, because this is a very rare disease nowadays, they don't carry it. I can say that most EDs don't have it, although it's very cheap.
And then this was a follow-up. So we have a comment that I understand there are no true brown recluse spiders in Arizona. Is there something similar, a cousin perhaps?
They are actually, there are 4 or 5, depending on, there's the Loxosceles reclusa that we don't have, but we have the Kaibab, the Zertica, there is the Apache, and there's another one. And I remember when one of our colleagues, who was an entomologist here, there was one that was isolated in Sabino Canyon, and they called it the Sibania, but I haven't seen the papers on that. But we do have our own, and the Zertica is also known as Tucson recluse. It looks a little bit smaller and a little bit less agile, but it can cause the same disease, and we have seen it. Now, is it something that you see every day? No. Compared to Louisiana, Texas, we don't see it as often, but it does occur. It's whether people recognize it, but we know it occurs. I lived in Louisiana, actually in Shreveport, similar to Dr. Klotz. We have lots of things in common, and that's one of them. I live in Shreveport, and for a while, I lived actually with a friend in their guest house, and guest house wasn't used as often. And I slept on the bed in that guest house, and I would tell you, every morning I would wake up, and there would be a brown recluse that was in Louisiana that was around, and I never got bit. I slept in that bed for a month before I moved back to Arizona, and I did not get bit. Most of the times with both the black widow and Arizona recluse, it's either they're trapped in the bed or the sheeting, or somebody puts their hand on them and they feel threatened that they attack.
Gotcha. And then going back to the antivenom, what's the shelf life look like on the product that's available?
I think Merck still makes it. With antivenom, remember, the antivenom that we have is lyophilized, so it's dried out powder. And I can tell you that usually with these, they give them a 2-year, but looking at other antivenoms and that they get an extension on it, it's probably in 10, 15 years if it's, kept in a cool, dry area. We had one time individual that they presented to a hospital, and they had what you call expired antivenom. And the father of the child that was envenomated was an orthopod, and well understood that the hospital cannot charge for expired medication, and but knew that it actually would resolve the toxidrome or the syndrome, and they chose and asked for it to be given, and we gave it to the child, and the envenoming resolved. So that was one of the smartest patients I had.
All right. Any other questions? Last call. Oh, we did get one. Goodness, now they're just coming through.
What's the question?
Do they carry anything in the pharmacy to help the Wildcat football team win?
That's beyond my capabilities. I think that's not either toxicology or infectious disease. We got to go into another talk, the performance enhancing agents.
Goodness gracious.
I had a question for Dr. Klotz with regard to tularemia and the airborne nature of it. So is it from the beaver's stool and urine?
Well, it's like most of these small mammal and dog and cat exposures. It may be on the hair. It could be anything. So it's often aerosolized. I just remember the most unusual case I had was a dog handler in Kansas City who had a typhoidal presentation of tularemia. And we hadn't seen in Kansas City for some time anything but tick-related tularemia. So they always had cutaneous eschars and lesions that were constantly ulcerated and regional adenopathy. But, as you well know, I mean, the most famous type of aerosolization is when the people particularly in Cape Cod and so forth, there's some famous stories of people who mowed cottontail rabbits and then they were infected and they inhaled the Francisella tularensis. And actually, Dr. Poe a year ago presented a case of a Arizonan who had been mowing lawns up in Minnesota, ran over rabbits, came down and had tularemia, but it was a pneumonia presentation.
I remember that one.
Yeah.
Dr. Poe presented. But when we say that, with going over the lawnmower over the animal, that would be tissue and blood.
That's right.
But when you showed the beaver sort of dam, would that be more from the stools and urine? Does the stool and the urine has a high content of the tularemia?
Well, I'm not really sure. It's like, another related thing to beaver dams and homes is blastomyces dermatitidis. If you
Okay.
stir these up, there's feces, I have no idea, hair, shafts, whatever you inhale, you can end up with this airborne fungal infection, as you can tularemia. So it's a favorite of the bioterrorists because it's so easily aerosolized. Something like anthrax is a little more difficult. You've got to mill the spores and all this kind of stuff. It's more of a technical achievement than it is with tularemia.
And then we had another question actually for you, Dr. Klotz. So on the tularemia aspect, can we assume that in the southern end of Arizona that this might also be present in pack rat nests, like most of the Southwest sees for prairie dogs?
Well, no, because most of the prairie dog towns are up, in northern Arizona on the higher elevations where you have freeze and thaw. And although honestly, animals like coyotes and stuff can traffic many different things south, and they do, uh, including anthrax, actually, or Pasteurella pestis. That's a favorite one that coyotes often don't get ill, but they eat animals that are infected and can pass this pathogen around. So it, I, it's been noted in rock squirrels, for example, the outbreak in, there was an outbreak in Yosemite that was related to rock squirrels, which we have in southern Arizona. Just a lot of small mammals that can be infected. And it's unpredictable, basically.
Interesting.
But it's something to think about. But in human beings whom you might suspect might have it, who'd show up at an ER or something like that, you're probably going to get a story of, well, I was camping in northern Arizona and we had whatever around us, or I was kayaking on the Colorado River, I was bitten by deer flies, and deer flies are the major um, uh, vectors of F. tularensis in the West, but it's not all in that fashion. I mean, it can occur with ticks as well.
All right. Last call for questions. I think we have got through. We got a lot of good ones today. This was an
Yeah, well, I
interesting.
think hopefully people will let us know what they still want to hear because we've still got a little time. And Dr. Shirazi, I volunteered you and Larry and I to meet in December, decide what we're going to do in the following year. So,
I think we still have the plants.
yeah, you've got some plants you want to talk about, toxins and allergies.
Yeah, so they're interesting plants that people either cook and eat, or they don't cook or eat, or they rub against them and stuff. So there's still that if you're interested in doing.
Well, yeah, and Larry already covered quite a few plants in his psychedelic presentations.
Oh, yeah, that's a different thing. That might help U of A win the football.
Oh, we had let's see, I just saw it, got out of my eyes. So, unrelated to at least today's talk, but something we had talked about before, How often do you prescribe Anascorp for scorpion stings?
So,
Since we got a bit of
Well,
time.
so you do not prescribe Anascorp because, again, it's one of those antivenoms that you give it when somebody needs it. They're expensive enough here in the US that nobody prescribes it. I don't recall anybody asking me, can you prescribe me for Anascorp? I'm going to go camping or something. Because most of the time it's a disease of, the scorpionism that we see here. It's the disease of really young children. We're talking about mainly under age 1. And then going up under age 5. So those, when they get envenomated, they can have lots of hypersecretions. They can have lots of movement disorders and then non-cardiogenic pulmonary edema that can actually cause them to have hypoxemia and then become brain dead or have a damage because of that. And that's why we use it in children. And I think if you're going to use it in children, the way to give it, unless it's very mild presentation, so there's no hypersalivation, there's no movement disorder, then one might want to give 1 vial. But if you see the full syndrome, as was described from our center, the syndrome in the children is the movement disorder with hypersecretion, putting the child at risk of airway compromise. That needs to be treated with 3 vials because 85% of people in the trial that we had responded to 3 vials. And if you have somebody who persists, then you need to give 1 vial every half an hour. And usually, we did not see anybody that stopped by more than 5 vials. And in the larger trial, there was 4.5 vials was the average number of vials used to terminate what we call the toxidrome. So cranial nerve involvement, you see the eye movement, hypersecretion, and then you can see the peripheral movement disorders of arm and legs. That needs to be treated. And the smaller the child is, the higher at the risk of airway compromise and hypoxemia and then airway death.
I meant to send everyone who had signed up for this an invitation to go to Portal, Arizona, because each year we have a retreat that we hold down there. We've been doing it for over 20 years, and we have brief talks and then a dinner later, and we stay at Cave Creek Ranch, which is just a beautiful place to be. And this year, one of the attendees, Mazda, found a Cash's scorpion in their cabin. It's about a medium-sized large scorpion that's entirely black.
Mhm.
And so that was entirely different. But I know that when we wrote a paper on scorpionism, there are approximately 54 species of scorpions in
Wow.
Arizona. I mean, who would know
Only
this
one
stuff?
species that has a health effect or is clinically significant.
That's right.
So, and again, in a very small population. So I would say we see it about maybe 50 people that, if you look at, they really require it, and usually children. And then maybe another 50 times it's used in Arizona because it's an elderly patient who's having lots of movement disorders. They're having a hard time eating, enunciating, talking because of the cranial nerve involvement, and they usually give them maybe 1 or 2 and terminate that. One of the worst ones I saw in an adult was an elderly female who was bedridden, and the scorpion fell into the bed from the ceiling, and she actually rolled on the scorpion, and who knows how many times she was envenomated. But she was having lots of movement disorders, her eyes, she was foaming at the mouth, and she really required it to help her because she couldn't even eat. So no, she wasn't at the risk of death, but she was at the risk of other complications. So it's nowadays, fortunately, with the Anascorp being available on the market, we can help those 50 children that really need it. We see we don't know whether it's the, weather or the environment and the weather changing, the climate change, but now we're seeing it. Last one we saw that required and they couldn't get antivenom was actually in Houston. And it was in an apartment complex that got a child that was a little bit older. It was, I believe it was 6 or 7. And the child had the full syndrome, and Texas Children contacted us. But unfortunately, again, getting antivenoms when you need it, it's not that easy. And by the time they got the antivenom to Texas Children, the child's syndrome had terminated, and fortunately, the child did not have a bad outcome.
I want to thank Dr. York and Dr. Shirazi and Dr. Klotz for giving us another fascinating and amazing educational webinar. My colleague Chris has put into the chat the link to the survey. As Dr. Klotz said, please complete that survey. That is how we know the material that you want and need to hear. And then a copy of today's webinar recording is also posted. It will be posted at the end of today, and Chris has also put a link to that. I also want to give a shout out to our YouTube channel. If you want to see any of our past webinars, they are all hosted there. And with that, gentlemen, thank you for being here with us today. And to those who joined us, thank you so much for joining us. We look forward to seeing you again soon.
Thank you. Bye-bye.
Have a good one.